Good afternoon, everyone. Pediatric Center of Excellence, KSCH, New Delhi, welcomes all the participants for today's Regional Distance Learning Seminar session. Today's topic is introduction of DTG 10 mg dispersible and scored tablets for CLHIV weighing less than 20 kg. And the speaker is Dr. Praveen Kumar. Dr. Praveen Kumar, sir, is the Director Professor with the Department of Pediatrics and the Deputy Program Director, Pediatric Center of Excellence at Kalavati Saran Children's Hospital, New Delhi. He is also a technical group member for the Government of India on nutrition programs. We welcome you, sir, for today's session and request you to start the session.
Okay, so thank you, Swati, for introduction, and very good afternoon to all of you, all who are attending this. So, as introduced, we are going to discuss about DTG, particularly for its use in CLHIV weighing less than 20 kg. So I think you must be using this in older age group or the children or adults weighing more than 20 kg. So this is something which has been added to the basket, whatever we had. तो इसके बारे में थोड़ा बात करेंगे. I will use Hindi, English both so that you all are comfortable. So ये new जो drug है dolutegravir DTG जिसके नाम से जानते हैं, तो pediatric जो strength है that is 10 milligram, and this is dispersible tablet. So we will just discuss about this. ओके, सो ये हम सब लोगों को मालूम है कि जो HIV से जो ग्रसित बच्चे हैं, तो जब हम ART देते हैं उनका मेन क्या गोल होता है. सो बेसिकली वी वांट टू प्रोलॉन्ग देयर सर्वाइवल. हम उनकी जो सर्वाइवल को इंक्रीज करना चाहते हैं. साथ में जो बीच में इनमें जो अपॉर्चुनिस्टिक इन्फेक्शन है, जो मॉर्बिडिटी होती है, उसको इम्प्रूव करना चाहते हैं. ओवरऑल उनकी क्वालिटी ऑफ लाइफ है उसको इम्प्रूव करना चाहते हैं. There is some raised hand. Tell me.
No, sir. We can continue.
Okay, right. So the most important is that by use of these ART, you enhance their immunity so that they are not suffering with or the opportunistic infection which they are predisposed. They are usually protected from that, and there is suppression of HIV replication. So that is the whole purpose. However, one important aspect in children management and adult, the difference is that childhood is the age when there is a rapid growth, and it's very important that we promote optimal growth and development. If we are giving and we are not able to do, then that will overall compromise their overall weight, their height, and other aspects. So that is something also we have to keep in mind when we are selecting some ART drug, and when we are choosing that drug and we are putting them on this. So what is the optimal ART regime for children? And children now should be initiated or transition to optimal new ARV drugs, that is DTG 10, which we are going to discuss. है ना? क्यों हम इसको ऐड करना चाहते हैं? Because जो हमारे पास एविडेंस है, जो हमारी स्टडीज है, जो बाकी जगहों की एक्सपीरियंस है, जो ओल्डर एज ग्रुप का एक्सपीरियंस है, दैट इज सेइंग दैट इट इज मोर पोटेंट टू रैपिडली अचीव एंड मेंटेन वायरल सप्रेशन. हम सब लोगों को पता है कि हम ART इसीलिए देते हैं ताकि उनका वायरल सप्रेशन हो, है ना. क्योर के केस रिपोर्ट्स आने लगे हैं, बट लार्जली हमें ये पता है कि इस जो डिजीज में क्योर होना जो है डिफिकल्ट है. सो ओवरऑल हमारा एम होता है कि हम उनके वायरल एप्लीकेशन को कम करके रखें ताकि उनमें ज्यादा प्रॉब्लम नहीं हो. सो ओवरऑल ये पाया गया है कि जब DTG 10 का यूज करेंगे तो ये दैट विल बी मोर पोटेंट and we will be able to achieve and maintain viral suppression. Then second is that we also know that what is the main problem? That we put them on some first line drug. After some time, they develop resistance. Then we have to go to second line drug. And many a times we do not have anything to offer after that. So overall, जो aim है कि by adding this DTG, what we will be able to do is that हम जो first line और second line की duration को increase कर सकते हैं. जो तीसरा सबसे important reason है इसको add करने का, हमें ये पता है कि ART में सबसे बड़ी क्या समस्या है कि नंबर ऑफ पिल और उनको खाने की जो चैलेंज है उसके वजह से उनकी एडहेरेंस में प्रॉब्लम होती है. तो डीटीजी के ऐड करने के बाद जो उनकी पिल बर्डन है वो कम होगा और इट इज इजी टू एडमिनिस्टर बिकॉज आप उसको तोड़ सकते हैं, उसको डिजॉल्व कर सकते हैं, है ना. सो एडहेरेंस जो है ओवरऑल इसकी इम्प्रूवमेंट होने की ज्यादा संभावना होती है और इसलिए हम इसको यूजुअली लाना चाहते हैं. नाउ जो अभी हमारी जो गाइडलाइन है अब उसमें DTG 10 को ऐड किया गया है विच इज नोन एज एस्को डिस्पर्सिबल टैबलेट. जस्ट अ मिनट, हेलो. अच्छा, मैं एक सेशन में हूँ, बात करते हैं. So now this has been added for CLHIV less than 20 kg and we have to initiate. और जो पहले वाले जो regime है, अगर पहले से बच्चे जो ART पे हैं उनको भी हमने transition करना है to DTG 10. We will discuss this in detail. So what are the advantages of DTG 10 and why we want to add that this is a new and improved ARV drug, एंटीरेट्रोवायरल ड्रग. इसे FDA ने अप्रूव किया है एज ए डिस्पर्सिबल टैबलेट फॉर इन्फेंट एंड चिल्ड्रन जिनका वेट 3 kg और जो 4 वीक्स से ऊपर बच्चे हैं उनके लिए इसे अप्रूव करा है FDA ने. जो एविडेंस के अनुसार ये बताती है कि DTG को अगर हम कंपेयर करें जो हमारा रिटोनावीर बूस्टेड लोपिनावीर जो पहले हम यूज करते रहे हैं तो उससे जो है ये सुपीरियर है. पिल बर्डन जो है कम होगा और दिस इज नाउ अवेलेबल अंडर प्रोग्राम एंड दिस इज डिस्पर्सिबल एंड स्कोर टैबलेट. जो यूजुअली पिल बॉक्स DTG का डिस्पर्सिबल टैबलेट की जो आती है उसमें 30 टैबलेट्स होते हैं और this is also being used for drug sensitive tuberculosis which we will discuss later on when as we will move. So now coming to this point, हम जो NRC ART initiation करते हैं जो first time in CLHIV. So this is the algorithm most of time you will follow, that we have to confirm HIV infection. We do virological and serological testing. The first step जो आप और हम करते रहे हैं पहले भी कि we have to treat and stabilize. अगर उस बच्चे में कोई भी opportunistic infection है या कुछ acute condition है like pneumonia or whatever, that we have to do. फिर हम उसकी baseline CD4 करते हैं और other lab investigations as per our NACO guideline. Then we have to take weight of the child, right? And if suppose the weight is less than 20 kg, there now the option is that we will add this DTG first time if the child is coming. So you will have the regime which is ABC plus 3TC and DTG 10. Or this will be AL plus DTG 10, right? But when the child's weight is between 20 to 30 kg, then in this age group who are more than 20 kg, here DTG 50 will be added and here the regime will be ALT. And if the child is more than 10 kg and you have done this and weight is less than 30 kg, so that will come under 20 to 30. So then you will choose this regime. And if the age is more than 10 kg and the weight is more than 30 kg or equal, then we have to take care of whether there is any renal disease or not. If there is renal disease, then you will use what we discussed later. But if there is no, then you will use, and you are using the other regime, which is TDF, 3TC and DTG, TLD. So you have already these details on Annex 2 of our national guidelines. So you can just refer to that dose, pediatric dose chart whenever there is any you need to confirm these doses. So now coming to the transition to DTG 10 based ART in CLHIV with weight less than 20 kg, which we are going to discuss. So there are two scenarios. एक तो ये हो सकता है कि पहले से ही है बच्चा और आपने ART उसको ऑलरेडी स्टार्ट किया हुआ है, एंड अभी जो टोटल ड्यूरेशन ऑफ ART है विच इज लेस देन 6 months. In these cases, you can do transition without viral load testing. And here what you will do, you will transit to DTG10 with existing NRTI, and you will replace this lopinavir with DTG10. So just उसके जगह आप DTG10 यूज करेंगे. जो डोज है that we have already discussed, but you have a drug dose chart which will help you in calculation. But आपने एक बार जब चेंज कर दिया DTG पे, so then what next? You have to repeat this viral load after 6 months of transition. That you will be doing. So transition जो है आपने किया without viral loading, but जब एक बार DTG पे आपने डाल दिया तो उसके 6 months के बाद you have to do this first viral load. And then after that, you will be doing as per our existing guideline. But दूसरी पॉसिबिलिटी ये है कि आपके पास जो बच्चे हैं वो who are having weight less than 20 kg, but वो बच्चों में already more than 6 months का ART हो गया है. In those cases, you will first do viral load testing, and अगर उस बच्चे में अगर लास्ट 3 months का अगर वायरल लोड अवेलेबल है, देन यू कैन यूज दैट फॉर टेकिंग डिसीजन. सो ये डिसीजन क्या होगा कि अगर वो वायरली सप्रेस्ड है, देन वी विल डू ट्रांजिशन टू DTG डायरेक्टली. एंड if the child was taking this AL plus lopinavir, then you will shift to AL plus DTG10. And if the child was on ZL plus lopinavir, then we will change to ZL plus DTG10. And I discussed for dose, you will be using your pediatric drug dosage chart. But suppose the situation is that we do not, the viral load is not suppressed. That is the second possibility. What to do in that case? इन केसेस में क्या करना है अगर वायरल लोड पूरा सप्रेस नहीं है? तो सबसे पहला स्टेप है कि उसमें आपको एडेरेंस काउंसलिंग पहले करनी है फॉर 3 months, एंड वी हैव टू कंटिन्यू सेम रेजिम. Then you have to repeat viral load when adherence is more than 95% over 3 consecutive months. 3 महीने लगातार अगर उसकी adherence more than 95% है, तो जो रिपीट वायरल लोड के साथ आपने सैसेप की गाइडलाइन के अनुसार, सैसेप के जो भी गाइडेंस होती है उसके अनुसार यू हैव टू ट्रांजिट. So that you have to remember. Hope it is clear what we have to do when the viral load is suppressed and what we have to do when it is unsuppressed. So this is the chart which I'm talking about the pediatric dose, how much you will be giving. So scored and dispersible tablet, how much dose we have to give for different weight band. So as you can see here, this is what you must be using. I think most of you must be using these charts. So we have guidance for what is, if the weight is 3 to 5.9 kg, 6 to 9.9, 10, or whatever is the weight of the child, you can select and decide according to this. So how we are going to do this transition, just to again summarize that if the current regime is AL plus lopinavir, ritonavir, and the viral load is suppressed, then we will shift to tablet AL plus this DTG 10 milligram. But if it is unsuppressed, we will be guided by HB, and if HB is more than 9, then we'll give ZL plus tablet DTG. If it is unsuppressed, then we will give this abicavir amivudine plus tablet DTG. And this transition for unsuppressed cases will be done under guidance of pCoE SASEP or SASEP. If suppose the child is on ZL and lopinavir, then again our decision will be based on whether the viral is suppressed or unsuppressed. So if it is suppressed, you will shift to tablet ZL plus tablet DTG 10 milligram. But if it is unsuppressed, so then the decision will be whether the child is exposed or not exposed to abicavir. If the child is previously not exposed to abicavir, then you will add tablet AL plus tablet DTG. And if the child is already previously exposed to abicavir, then we will shift to tablet ZL plus tablet DTG. And as I have mentioned previously also, for unsuppressed cases, we have to take guidance from pCoE or SASEP. So just to highlight what is the dose of DTG which is recommended, as you can see here on the screen, for childs weighing 3 to 5.9 kg, it is half of the tablet. So this is known as dispersible tablet because it dissolves in water quickly. And you can also break this without any difficulty. So many tablets, you will have a lot of difficulty. And many times when you will break, the size may not be correct. But however, these tablets you can break. And that's the reason it is known as scored and dispersible. For 6 to 9.9 kg, the dose will be 1.5 for and you can select. And so please remember, but however, that the dispersible pediatric DTG is not equivalent to the film coated DTG which you were using or adult tablet, because these are dispersible DTG. So most of time, and this is dissolved. So 30 milligram dispersible DTG is equivalent to one film coated 50 mg, because the absorption is different from these dispersible tablets and the film coated this 50 milligram DTG. So if we are using this dispersible DTG, only 3 tablet, the 3 tablet will be equal to their 50 mg DTG. So that is what we have to remember. And the dosage of the other drug you are using twice. And one of the major advantages is that you are using once a daily for DTG, right? So that is something which is major advantage with this drug when we are using. However, the total dose, there is some difference when this is used in drug sensitive tuberculosis, weighing less than 20 kg, because there is drug interaction. So in these cases, particularly drug sensitive tuberculosis, we are using twice the dose which we were using in routinely in children without tuberculosis. So how much we give? You give only half tablet, but now we initially we were giving once daily. Here you will be giving twice a day. And if the child is more than 20 kg, then you will be giving DTG 50 twice a day. So that is what we have to remember, that if we are using this in drug-sensitive tuberculosis, then we have to use twice the dose which we are using for tuberculosis-negative children. So now it is very important that you also counsel the caregiver or parents regarding these newer drug, because we know we have limited number of drugs and we can't afford to misuse it. अगर हम इसको मिसयूज करते हैं, हमारे पास बहुत ज़्यादा ऑप्शंस नहीं रहता, तो इसलिए इट्स वेरी इंपॉर्टेंट दैट वी हैव टू काउंसिल, एंड प्रोबेबली दिस इज व्हाट यू ऑल आर डूइंग फॉर अदर ART drugs also. But same time, you have to explain these things to caregiver and children living with HIV. What are these? That you explain need for lifelong ART and importance of adherence and viral suppression. वो आप कर रहे हैं कि अगर वायरस सप्रेशन नहीं होता है तो उनके शरीर में नुकसान होता है, उनकी इम्यूनिटी खराब होती है, उनमें जो है इन्फेक्शंस का डर ज्यादा होता है. Why they have to adhere? Why you want all children their adherence should be more than 95%? So these are the things you have to explain. You also need to explain the benefit of DTG10. हम क्यों लाना चाह रहे हैं, क्यों आप शिफ्ट कर रहे हो, उसकी इंपॉर्टेंस आप बताइए. Because it is more effective, it is safer, it is easy to administer because it's dispersible. साथ साथ उनको आपने हर ART की कुछ ना कुछ साइड इफेक्ट्स हैं, एंड रूटीनली वी कन्वे दिस टू caregiver. बट ये बहुत जरूरी है because now this is a newer edition. So you explain the rare side effect which DTG also, particularly in older or the children with more than 20 kg, whatever the experience we have, that अगर ये लगता है कि इंसोम्निया है, फैटीग है, हेडेक हो रहा है, और या रैश कोई डेवलप करता है, so then it is to be reported immediately. साथ साथ ये भी जरूरी है कि हमें ये बताना है कि DTG की वजह से थोड़ा वेट गेन हो सकता है, and it is very important that they should have regular exercise and nutritional counseling, which we do anyway for lifestyle changes, ना. So उनको एक्टिव रहने का, रेगुलर एक्सरसाइजेस की, जो हम न्यूट्रिशनल काउंसलिंग रिगार्डिंग द बैलेंस डाइट which we give, that we should give. Now explain how to give the drugs. For that we have 10 steps which will be discuss this in next slide. You also specify dose and tell them that ये जो डोज आप डिसाइड कर रहे हैं वो बच्चे के वेट के अनुसार है, और अगर बच्चे का वेट चेंज होता है so then the dose also will change. One another important point is all of us we know these ART drugs or any other drug, many it's not only for ART, the other drugs also, we always tell that when they have to take. ये कॉमन क्वेश्चन होता है कि वो पूछते हैं आपसे खाली पेट लेना है, खाने के बाद लेना है ना. तो ये बड़ा जरूरी है कि DTG को जब आप फर्स्ट टाइम इंट्रोड्यूस कर रहे हैं तो यू हैव टू गिव दिस, that they should have a fixed time for giving these drugs, which we anyway advise for other ART drug also. And ideally the DTG should be taken 2 hours before, yeah, 6 hours after taking drugs, like if suppose they have taken antacid, laxative, sucralfate, आयरन सप्लीमेंट चल रहा हो अगर बच्चे को, ओरल कैल्शियम, तो हमें ये बताना है कि वो 2 घंटे पहले ले उन दवाइयों के, या 6 hours अगर वो ड्रग्स ले लिया है तो फिर उसके 6 घंटे बाद. But same time, it's very important that they should maintain whatever time they decide, that should be maintained every day. They should give that around that only. Now coming to the counseling, which we discussed, that we should give information that how to give this. So what all we have to discuss. पहला तो ये बताना है उनको कि जो DTG 10 मिलीग्राम की जो डिस्पर्सिबल टैबलेट है, इसे एक ड्रिंकिंग वाटर जो भी वो घर में यूज कर रहे हैं क्लीन कप में लेके यूज करना है, एंड देन दे हैव टू यूज रिक्वायर्ड नंबर ऑफ टैबलेट जो भी हमने पीडियाट्रिक एज के अनुसार कैलकुलेट किया, और उसमें एक मेजर्ड अमाउंट ऑफ वाटर डालना है. हाउ मच अमाउंट वी हैव टू ऐड, दैट इज रिटन हियर बाय द साइड. कि अगर हाफ ए टैबलेट टू 4 टैबलेट है तो द अमाउंट ऑफ वाटर विल बी 5 ml टू 10 ml. इतनी पानी में उनको घोलना है. अगर ज्यादा में भी घोलते हैं तो प्रॉब्लम है, कई बार बच्चा पूरा नहीं पी पाएगा, और अगर कम में देते हैं तो भी वो काफी कंसंट्रेटेड होगा, और थोड़ा भी अगर बच जाएगा तो आपकी ड्रग्स जो है बर्बाद होगी और बच्चे को मिलेगा नहीं, और जो हम डिजायर्ड चेंजेस चाहते हैं वो नहीं हो पाएगा. अगर बच्चे ने को आप अगर 10 मिलीग्राम वाली टैबलेट को कंबाइन करके दे रहे हैं विथ AL एंड ZL डिस्पर्सिबल टैबलेट, तो वहां पे हमें 20 ml ऑफ वाटर यूज करना है, विच इज इक्वल टू रफली जो 5 ml वाली जो स्पून होती हैं उसकी 4 टीस्पून के बराबर होता है. तो ये हमने देखा कि जो अमाउंट ऑफ वाटर है ये डिपेंड करता है कि नंबर ऑफ टैबलेट कितना देना है. अब जब आपने उसमें डाला और पानी एक कप में डाल के उसमें डाला, तो आपने अच्छे से उसको घोलना है कि ताकि उसमें कोई लंप नहीं रहे, और आपने जैसे ही बनाया उसको इमीडिएटली दे दीजिए. हमें ये जरूर ध्यान रखना है कि जब भी हम बना रहे हैं विद इन 30 मिनट्स उसको कंज्यूम करना है. जब आपने बच्चे को पिला दिया तो थोड़ा अमाउंट ऑफ वाटर फिर से दोबारा कप में डालिएगा, ताकि कोई जो रिमेनिंग मेडिसिन है दैट ऑल्सो गोज टू द चाइल्ड. जब आपने दे दिया उसके बाद थोड़ा एडिशनल वाटर आप दे सकते हैं, ताकि बच्चे ने जो लिया है उसके माउथ में है वो भी इट गोज. जो बच्चे बड़े हैं और अगर वो डायरेक्ट टैबलेट निगल सकते हैं तो दैट इज अलाउड. अराउंड 5 years ऑफ एज, 5 साल 6 साल वाले जो बच्चे हैं. बट ये ध्यान रखना है कि अगर 2-3 टैबलेट खाना है तो एक एक करके खाएं, ताकि चोकिंग की पॉसिबिलिटी नहीं रहे. और जो जैसा मैंने पहले भी बताया आपको कि अगर उसको तोड़ के देने की जरूरत है, जैसे 0.5 या 1.5 देने की है, तो वहां पे हम उसको तोड़ सकते हैं, स्प्लिट कर सकते हैं. बट ये ध्यान रखना है कि हमारा हाथ है वो ड्राई और क्लीन हैंड्स होने चाहिए, अदरवाइज वी विल नो एक्सपोज द चिल्ड्रन टू द इन्फेक्शन. अगर आपने हाफ टैबलेट दिया है या 1.5 दे रहे हैं, तो जो अनयूज हाफ टैबलेट है उसको इमिडिएटली बोतल में डालना है, ताकि मॉइस्चर और उससे जो है बच पाए. अब कई बार जो हमारे जो ये बच्चे होते हैं वो दे हैव यूजुअली मल्टीपल ड्रग्स. कई बार उनमें सीजर की हिस्ट्री होती है, कई बार उनमें एंटी कन्वल्सेंट ड्रग्स भी चलता है. तो ये हमें ध्यान रखना है कि कुछ एक ऐसे ड्रग्स हैं जिनका इंट्रैक्शन नोन है कि ये अगर आप DTG दे रहे हैं तो वहां पे ये प्रॉब्लम हो सकती है. तो जैसे एक कार्बाजेपिन है, जैसे जिसको कई बार हम टेग्लिटोल जो कमर्शियल नाम है उसके नाम से जानते हैं, अगर बच्चे को ये मिल रहा हो सीजर के लिए, तो हमें ये ध्यान रखना है कि जैसे हमने टीबी में बात करी थी कि चाहे तो अगर हम DTG पे डाल रहे हैं तो ट्वाइस डेली डालना है, या आप जो भी उनके ट्रीटिंग फिजिशियन हैं उनसे ये बात कर सकते हैं कि क्या ये टेग्लिटोल की जगह कोई दूसरी अल्टरनेट एंटी कन्वल्सेंट लाइक भालपेरिन or we are using levocetrim these days. So that may be used in place of carbamazepine. Similarly, if the child is on phenytoin, because there is possibility of enzyme induction with these drugs, तो हम यूजुअली कोशिश करते हैं कि उसको कोई अल्टरनेटिव एंटी कन्वल्सेंट ड्रग्स पे चेंज कर दें. आई हैव ऑलरेडी डिस्कस, मैंने पहले भी बताया आपको कि अगर बच्चे को ऑलरेडी कुछ आयरन, मैग्नीशियम, जिंक ऐसी वाली प्रिपरेशन मिल रही है, तो हमें ये ध्यान रखना है कि जो DTG की टैबलेट है उसे उसके 2 घंटे पहले खाने के या 6 आवर आफ्टर उन ड्रग्स के हमें देना है. अगर बच्चे में कुछ रिफाम्पिसिन जैसे ड्रग सेंसिटिव ट्यूबरकुलोसिस है और बच्चा रिफाम्पिसिन पे है, तो वहां पे मैंने पहले ही बताया आपको कि DTG को ट्वाइस देना होता है, जहां पे हम दूसरे बच्चों में वंस डेली देते हैं. इनकी डिटेल्स भी आपकी नेशनल गाइडलाइन जो 2021 है उसकी चैप्टर 2.2 में डिटेल्स है, जो 2.2.6 पे, तो आप उसको रेफर कर सकते हैं कुछ और एडिशनल और जस्ट कंफर्म करने के लिए. So what we have now, we have one exercise which the first one I will discuss, and then the others I will request all of you to do using chat option. So suppose the child is 6 years old and the weight is 13 kg. This is a male child. HB is 8 gram per deciliter. और ये जो हम बात कर रहे हैं वो इनिशिएशन की बात कर रहे हैं. पहली बार जो है हम इनिशिएट करने की डिसीजन ली है हमने. So what are the drugs which we are going to give? So in this case, you can see here, in this case, we will be starting AL plus DTG10, and the recommended dose will be 2 tablets twice daily for AL, which is 60 and 30, right? ये है 13 kg जो मॉर्निंग में है, 2 tablets, right? Morning and evening. And how much DTG? We will give DTG of 2 tablets once a daily, because यहाँ पे tuberculosis नहीं है ना. And we will also use hematinics. हम आयरन सिरप डालेंगे, बट वो ध्यान रखेंगे कि DTG को हमें कैसे देना है 2 hours बिफोर, जो हमने बात करी है. Now you have second scenario, and this is for all of you. This is exercise for you, and what I request all of you to write in chat. Shweta, I think the chat function is functional.
Yes, sir. Yes.
Okay. So you have this second child. This is 7-year-old whose weight is 19 kg. This is a female child. HB is 9 gram per deciliter. CD4 is 300 cells per cubic millimeter. And there is no AI. So I request all of you to write what is the drug which we will be giving and what dose you will give. Please write. I do not see any answer at this point of time.
Requesting all the participants to please put their responses in the chat box.
Dr. Hemant, please write the dose also, how much you will give. You have written ZL and DLT. No, Dr. Sandhya also, what will be the dose? It is just in front of you, by the side, it is shown. So we have just 3 responses till now. May I request others also to respond? No, not interested. Okay, so what we'll do in this case, as you can see here, 2.5 for 19 kg. So you will give AL 60/30, 2.5 tablet twice a day. And DTG 10, it is that we have to give 2.5 tablet once a day. Here CD4 count is low, so you will also give cotrimoxazole and tablet hematinics, you will have to give 1 tablet once a day. So that is the treatment which we will decide. So now coming to next one, 3-year-old child weighing 9 kg, male child. You do not have HB available. CD4 count is 400 cells per cubic millimeter, and there is no AI. Why? So may I request all of you to write now what dose, how much you will give. 3-year-old weighing 9 kg. Request all of you to write in chat one. I hope all of you are aware this meeting chat icon which is there.
At the bottom of your screen, you will find the chat option. In case you don't find it, you will find it in the option more, which has 3 dots above it. So please click on that. There is a chat option. You can click on that and you can type your responses. The chat option may appear on the right-hand side of your screen.
So many of you are not writing DTG. May I request also to add DTG also. Dr. Parminder, you are not written dose. Okay, so just to tell you how much this dose will be, see it is 9 kg. So we will select and it is 1.5 tablet, 1.5 tablet. So this is 1.5 tablet twice a day with DTG also 1.5 tablet once daily. Here we do not have tuberculosis or we do not have history of any drug which we mentioned like carbamazepine or tegretol, right? So that is the reason we will give once daily. Here again, the CD4 count is low. So we will give syrup cotrimoxazole 5 ml once daily. Now, this is the last one, last case scenario for you. This is a 4.5 months old infant diagnosed with HIV infected by DBS. The weight is 4 kg. There is no OI. So may I request all of you to write. This child has weight of 4 kg. What will be the dose and drug which you will give to this child? Only one, I think, answer so far. Neha. 0.5. So DTG, I think most of you know, but one of you have written 10, 1 tablet full, 1 tab twice daily. Okay. ART Sagwara, why twice daily in this case? Do we have any high problem like tuberculosis or the drug. This is a 4.5 months old, weighing 4 kg. So still there are some no problem here, because many of you have written full tablet, which is not correct. See, how much we have giving here is 0.5 tablet, which we discuss. So that is what the dose is here. See this, the last one. How much is the dose for 4 kg? It is 0.5. So that is what we have to remember. And this whole exercise was for that only, that we have to select and we have to use drug according to the chart which we have in front of us. So whenever you are prescribing, please refer to these charts and decide according to this. So thank you all who could respond and who participated in this exercise. So now I will move ahead. So when you have a started ART, there are certain other aspect of management that also is important, and these you are doing. But same time I know, because many a times when we discuss this in our session, then many a times usually the growth parameter, the nutritional profile is not usually well maintained. So it's very important that we have to maintain and record this growth and nutrition parameter every visit. Development you have to assess, you have to do screening for tuberculosis, you have to look for OIs, and you have to do staging. You have to look for treatment adherence at each visit. And then you also have to calculate ARB dose as per weight. If there is, suppose there is change in weight, then we have to change. So these details are there, drug doses, which we have already we have done exercise. And those who could not see very clearly, you can always refer to our guideline in Annexure 2 for this. So two important points, I think, other you must be doing, but growth and nutrition assessment needs to be done every visit. And we also need to calculate ARB dose as per weight. It's also important that you maintain their growth chart. And I do not know whether all of you are doing or not, but these charts are available in our national guideline as Annexure 7 to 12. And for less than 5 years, you have these pink for girls and this blue for boys. And you have to plot the parameters here, which is usually which will tell you that whether my child is gaining weight, if there is any growth problem, and then you can take remedial measures, whatever is the problem you can identify. And for children who are more than 5 years, we have these IAP recommended BMI charts, which we have to use. So I think try to maintain for each child, so that many times if it is well maintained, it is very helpful in taking decision when we have to take decision regarding the second line and other. Right. So now, if suppose you have some question, you can write in this using this chat box. And the meantime, I will also try to discuss certain other situation, special situation which we have. And many times you will have these questions or you will face these situations. And many times you will try to know what we have to do it. So what are these special situations? The first may be that viral load test is not done in last 3 months. and is not available currently, and also you do not have this lopinavir ritonavir stocks in your, so what you have to do? So in such cases, transition to DTG based regime should be done with existing NRTI backbone, and you can do because you do not have lopinavir ritonavir, so you will shift. However, please remember that as per our guideline, there is a need for enhanced adherence counseling, as we discussed, and also virological tests should be done after 6 months of transition to this DTG based regime. That is what we have to remember. We may have a second situation where we have a CLHIV child with unsuppressed viral load and undergoing so and your lopinavir ritonavir stocks are not sufficient, right? So in these cases, again may be done, and you can shift to DTG. Again, same that you have to do enhanced adherence counseling should be done to identify and address any adherence barrier to maximize their chances of success, because you are putting them on new drug. You do not want to fail again. And then you will again do this virological test after 6 months of transition, as we discussed in previous slide also. So the next is what to do if CLHIV is on second line ART, right? This child is on lopinavir ritonavir containing and the virally unsuppressed. Again, transition to DTG based regime may be done immediately. Enhanced adherence counseling, as we discussed, should be provided, and virological tests should be conducted after 6 months of this change in regime. And we all know what is the rationale. The rationale is that the mostly आप सब लोगों का एक्सपीरियंस होगा कि ज्यादातर जो सब अनसप्रेस्ड होते हैं वहां पे कंप्लायंस या एडेनेंस की सबसे ज्यादा प्रॉब्लम होती है. तो अब जो है नाउ सिंस वी आर चेंजिंग इट टू डीटीजी बेस्ड एआरटी, उसमें ये एडवांटेज है कि वो सिंपल डोजिंग शेड्यूल है, पिल बर्डन उनका कम हो जाता है, एंड हम उनको दोबारा जो है एक बार दोबारा काउंसिल करके डालेंगे तो इस बात की पॉसिबिलिटी ज्यादा है कि दे विल बी मोर एडहेयर टू व्हाटएवर वी आर एडवाइजिंग. It is also easier to administer than the other drugs where you have problems. Also, the experience tells us that it has better acceptance because this is a strawberry cream flavor. So usually this is more acceptable. It is more tolerated also with minimal side effect. The only rare side effect which I have already mentioned. And then the resistance is also less as compared to other drugs. Although these evidence are largely from children weighing more than 20 kg, but whatever experience we have from those age group or those weight bands, it is encouraging, and it is usually showing that there is good suppression of viral load among children who are put on these drugs. Now the next question may be whether we need any specific monitoring. So specific monitoring I have already discussed. Whenever the child is on ART, there are certain routine monitoring which we have to do as per our NACO guideline. The viral load monitoring, I have asked you to do it 6 months after DTG initiation. अगर पहली बार आपने डाला है या आपने अगर ट्रांजिट किया है तो 6 महीने के बाद आपने करना है. तो you will be doing newly initiated में 6 months or 12 months पे. और जो ऑलरेडी ट्रांजिशन आपने कर लिया वहां पे 6 मंथ 12 मंथ और फिर उसके बाद आप एनुअली करेंगे अगर बच्चा फर्स्ट लाइन पे है, और अगर बच्चा सेकेंड लाइन पे है तो 6 मंथ पे ही हमें करने की जरूरत है। इट इज इंपॉर्टेंट फिर हाइट और वेट की मॉनिटर करें जैसा मैंने आपको बताया है, एंड यू हैव टू प्लॉट एंड देन रूटीन ब्लड इन्वेस्टिगेशन जो आप एआरटी ड्रग पे होता है जब भी बच्चे, तो जो आप रूटीन इन्वेस्टिगेशंस करते हैं दैट आल्सो यू हैव टू डू। अब दूसरी सिचुएशन ये होती है कि सपोज कि आपने एज एप्रोप्रिएट डोज डीटीजे स्टार्ट किया, धीरे धीरे जो है बच्चा बढ़ गया, उसकी वेट इंक्रीज करा, नाउ द वेट इज more than 20 kg. What you have to do? So this is the algorithm which you have to use. Now, if the child is more than 20 kg, then you will transit to DTG 50 tablets. So what we were doing for weight less than 20 kg, if you were giving this ABC plus 3TC plus DTG 10, now you will change to, if the weight is more than 20 kg, then you will change to ALD. Right? And then if it is more than 10 kg, the initially also I have already discussed, if the weight is more than 30 kg, then it will go on TLD. So that is what you have to remember. With time, the weight will increase. And once the child is more than 20 kg, then we have to shift to this DTG 50 in place of DTG 10. So the earlier age criteria which was used, that there was criteria of this weight. Now that criteria is not there with updated dosing schedule, which has been recommended by WHO and TRG. So it's very important, and many a times if you are not careful, then many a times you will have some incorrect prescription. So as I have already discussed, these both drug film coated strength and dispersible strength is not same. So when we are using this dispersible tablet 10 milligram, then this should be swallowed at whole, but it should be dissolved in water. While this 50 milligram tablet is a small, there is a film coating on this, so that you can't dissolve and then use. So that was the major problem which we all were facing initially. Now, can AL be administered in the same solution with DTG? The answer is yes, you can do it. I have shown you that also, that we have to use 20 ml of water there. So only the amount of water increases. So DTG 10 can be dispersed and administered in the same solution of clean water as for AL. When dispersing both products together, we have to use 10 to 20 ml of clean water and ensure both medicines are properly dissolved before administration. If not dissolved, if there is a lumping, then you have to stir it slowly. You can add some additional water like 10 ml. If you have added, you can use increase to 15 to 20 till the time this is properly dissolved. Can DTG 10 milligram be mixed with liquids other than water, such as juice or breast milk? Breast milk you can do, but however, the most of time it is preferred that you use clean water. And if you are using with the child is not accepting, then the other choice is that we can use milk or juice or other bodies. But if we are giving this with other liquid or food, try to follow the same small volume recommendation so that the child is able to accept the full dose. Otherwise, if you have added in too much, and if the child is not finishing, then the child will not receive the full amount of drug which he should be given. Now, the another question may be that you have given, and suppose the child vomits. What to do in this case? Then if the child has vomited within 30 minutes of taking that initial dose, then we have to give another dose. And this is not only for ART, we follow this for malaria and sometimes other drugs also. So this is the usual gastric emptying time. Most of the time you feel if the child has not vomited for 30 minutes, then it has gone beyond stomach. And most of the time the drug will not, whatever you have given, that will be absorbed. But if there is a vomiting within 30 minutes, it's likely that the drug is also vomited and you will have to give the other drug. Can DTG containing ART be given at any time of the day? It may be given, but what we have to remember that we should give at the same time every day. And if it is twice daily, like tuberculosis and carbamazepine, which I have discussed, then we have to maintain this 12-hour difference between two doses. So that is the important thing which we have to remember. And also the other precaution, like if the child is taking antacid and other drug, which precaution which we have discussed. Are there any adverse effect of DTG? Usually not. It is usually well tolerated. In clinical studies, most of time there is some infrequent possible side effects like insomnia, fatigue, headache. The older children may complain. And as we have already discussed, that these are the things we have to capture whenever the child is coming for follow-up. Can the child be given another medicine? Because many a time that the child may have other comorbidities you can give. We have already discussed because of the interaction and with rifampicin, we are giving twice daily. Regarding certain food item, which we have already discussed, if it is co-administered, this should be at least 2 hours before or at least 6 hours of such formulation. So it's very important that we remember this. And if the child is on some anticonvulsant, we always have to see whether we can change that anticonvulsant. Can IPT be given along with DTG? You can give, there is no contraindication. And we have to use age-appropriate this isoniazid prophylaxis therapy, particularly children living with HIV, who do not report poor weight gain or they are not at high risk or you have unlikely of active TB, then we have to offer IPT. And also less than 12 months, particularly if there is history of contact and there is no feature or there is no possibility of active TB, then we have to start this TB preventive therapy as per our guideline. There may be one other situation that you have this problem that lopinavir, ritonavir stock will last only for a couple of months. So then it is very important that we switch, because we do not have that supply and there will be interruption in the drug. And already we have discussed that how we have to do it. So there are certain other also, I do not know what is the status. Most probably very, very soon you will have all this. I think maybe Swati can update on this regarding the job aids, frequently asked questions by. So these things also will be available to you for counseling the caregivers. Then I think we are aware that we have pCoE or SASEP frequently, and they will be involved in monitoring, mentoring. We already have this system, and we have SACs where they will be supporting ART center in proper transition plan, and they will also monitor transition. And there are pCoE who are linked with us, these are the states: Haryana, Madhya Pradesh, Uttarakhand, Rajasthan, Punjab, Uttar Pradesh, and I believe the participants are from these places. I think this all of you are using, so you will use for dispensing these drugs. So I think I will stop here, and so over to Swati. Yeah.
Thank you so much, sir. Any questions from the ART centers? Please feel free to unmute, or you can even type in the chat box.
I'm sorry for calling you Swati.
No problem,
Sorry.
sir. No problem at all.
Yeah.
That's absolutely okay, sir. Any questions from the participants? So I don't think there are any questions. Thank you so much for facilitating this session. Just to inform everyone, NACO is planning a session on case-based discussions on DTG 10 mg soon. We have already sent an email requesting queries or questions on this topic. So please open that email, and there's a Google form link in that email. In case you have any queries or any questions, please feel free to post your questions. You have to do that by 14th of October. Can we get this lecture PDF? So we'll you will get the PPT and the recorded link from pCoE KSCH.
Okay. Thank you.
All the ARTCs will be sent PPT and recorded link.
Right.
Thank you so much.
Okay.
Sir.
So thank you, Sweta.
Yeah, thank you to all the participants for patient listening and participation. We'll conclude the session now.